Good evening, friends. Welcome to the Tuesday Critical Care and Other Specialty Department CMEs and learning platforms of Yasodha Group of Hospitals. We are pleased to have Dr. M.B. Rao sir, who has been a senior clinician and a seasoned physician across the last maybe 3 or 4 decades, and a physician who has been looked for as a mentorship for many of the issues. So today we have Dr. M.B. Rao sir as an expert panelist to guide us through a known old friend like a dengue fever, which actually every alternative year created a havoc in the metro cities, including Hyderabad, and added to our current ongoing pandemic, how this dengue played a role. He will be expressing his expert panelism. And we have young dynamic Dr. Sri Charan, who has been a fellow in critical care and now heading the transplant critical care unit in Yasodha Hospital, Secunderabad. So Dr. Sri Charan will take us through the initial part of a review of literatures related to the dengue in this current pandemic, and followed by Dr. M.V. Rao sir's expert opinion. He actually is a senior clinician in Yasodha Hospital, Somajiguda. So initially, to start with, Dr. Sri Charan, over to you.
Sir, thank you, sir. So today we'll be discussing about the concept of dengue attack in COVID era. So I'll be guiding through the epidemiology of dengue and the various manifestations of dengue. Namely, especially during the COVID era, like we have dengue COVID co-infections, the shock syndromes of dengue, the organ failures, and we'll be concentrating mostly on the acute liver failure aspect of dengue because it's associated with significant mortality. Now, coming to the epidemiology of dengue, dengue actually is a more confined to this tropical and the subtropical areas of the world. Especially, it has been described that dengue is more endemic in the regions between 30 degrees north and 40 degrees south equatorial regions, especially the tropical and the subtropical regions, namely. So here in this map, this is the World Health Organization depiction of the incidence of dengue in the most recent days. So it actually shows that the India and the Southeast Asian countries especially are having a higher prevalence, or they are more higher prevalence of dengue than in the other states of the Asia. So here the interquartile range is lying between 5 cases per 100,000 population, but it's the incidence of dengue is much more higher because of its asymptomatic presentation state. Coming to India, in India we have various other it is actually divided into the high burden states, the moderate burden states, and the low burden states. So here we have the majority, as you can see in the picture, majority of the states in India are high burden states. So what are high burden states? These are the states where the disease endemicity is hyperendemic with mostly perennial transmission, repeated outbreaks, and it is actually involving majority of the districts in the state. And there are higher deaths due to dengue, which is caused by all 4 serotypes of dengue. We'll be discussing about the various serotypes of dengue later on. The moderate burden states are they are mesoendemic with seasonal or long transmission windows, mostly caused by single or 2 transmissions or single or 2 serotypes, with only a few districts affected. And the numbers are few. The number of deaths due to dengue fever are fewer in these subgroup of states. Whereas the lower group of states, especially the eastern, like northeastern states and Himachal Pradesh, so they are hypoendemic with seasonal with low short transmission, rare outbreaks, and only a few districts are involved, or there is not any outbreak involved. So this can be explained by relative weather conditions there, where it is the dengue requires a more tropical and subtropical areas for it to actually transmit it, because that is the very good breeding ground or a breeding temperature for the transmissible vector, namely Aedes mosquito. So this is the National Vector-Borne Disease Control Program data on the reported dengue cases in the last 6 years. So we can actually see that Andhra Pradesh and Telangana here, they have significantly higher number of cases. Until September 2021, this year, Andhra Pradesh has reported around 2,463 cases, whereas Telangana has reported around 4,610 cases. However, no deaths have been reported so far. That actually says that there are a lot of number of deaths which might be underreported, or there could be deaths because of dengue and other super infections. It might not be reported as dengue deaths after all. So what is our hospital data set? So we have actually treated across all our 3 centers in the last 3 months, we have treated more than 750 dengue positive patients. So what are the various challenges the dengue disease actually poses us in COVID times. So recently the government of India has actually given us a national guideline on the dengue case management during the COVID-19 pandemic. So these are the various challenges which actually occur during these COVID-19 times, include the overlapping initial presentations. So especially during a pandemic like ours, any acute febrile illness is treated to be or is presumed to be a COVID case unless and otherwise proved. But the thing is, we might have an initial clinical presentation and laboratory parameter overlapping, which might actually pose as a challenge in differentiating or in fact suspecting a dengue case along with a COVID case or a dengue case in spite of a COVID case. So there are unpredictable clinical courses that both generally require in-hospital management. So there is a high index of suspicion to be required to identify dengue and COVID-19 co-infections. So we'll be discussing in detail about dengue-19 co-infections and when to actually suspect a co-infection or a dengue in an acute febrile illness. And there is also healthcare infrastructure challenge. So that is because of the ongoing pandemic, there are a lot of resources which are diverted towards handling the COVID cases. So there is a healthcare infrastructure challenge in handling the other zoonoses, especially dengue fever. See, most of these cases of dengue-19 and COVID-19, dengue and COVID-19 are asymptomatic, so about 80%. So in a setting of co-infection, one might enhance the severity of the other, and most of the cases might even go unnoticed. So there are other treatment or like therapeutic challenges while we are actually handling dengue COVID-19 co-infection, especially with respect to IV fluid therapies or with respect to low molecular weight heparin therapies, which are proven therapies. One is fluid proven therapy in dengue, whereas the low molecular weight heparin, which is actually useful in COVID-19. So they have certain pharmacological or therapeutic differences between the management of these two cases. And coming to the investigative part, so in the diagnostically, we have a false positivity, which is also reported in both the cases. Especially the patient might be having a dengue fever and may throw a false positive, disease may throw a false positive infection. So we cannot actually say that there is a co-infection, because even our laboratory parameters, there is some degree of false positivity. And finally, both these drugs do not have any specific antiviral drugs. So that is the reason both of them, they have to be managed in they have to be managed accordingly, like symptomatically. Now coming to co-infection, according to these guidelines, so in India, there has been an incidence of co-infection, especially from the states like Assam, Chandigarh, Daman and Diu, Delhi, Goa, Gujarat, Karnataka, Kerala, Maharashtra, Odisha, Punjab, and Uttar Pradesh. And deaths due to COVID-19 co-infection with dengue have been reported from the states of Assam, Maharashtra, Punjab, and Delhi. So this is actually taken from these guidelines from the Ministry of Health. So how do we actually tackle an acute febrile illness during a COVID-19 pandemic? So because of an ongoing pandemic, this becomes an actual challenge in differentiating and in actually treating appropriately a patient with an acute febrile illness. So all the patients who are having an acute febrile illness, it is actually imperative that we get we rule out COVID-19. So a SARS-CoV-2 nasopharyngeal swab or oropharyngeal swab is with an RT-PCR or a rapid antigen test or a nucleic acid assay test. These are imperative in identifying or in management of a patient with acute febrile illness. So even if any of these tests positive, if the patient is having any non-specific symptoms or unlikely symptoms of COVID-19, especially with high-grade fevers, joint pains, retroorbital pains, typical morbilliform rash, symptomatically, and bleeding manifestations, or hematologically, if we see any raised hematocrit and thrombocytopenia, like that is a clinical suspicion of dengue. Even in this during this clinical suspicion of dengue, we have to take either an NS1 or an IgM levels. So if any of them turn out to be positive, it is a dengue COVID-19 co-infection. Even if it is positive and if the patient is not fitting into a clinical suspicion of dengue, we have to look or keep looking for any other suspicion of other tropical infections or any localized infections. The tropical infections include malaria, typhoid, leptospirosis, scrub, chikungunya, H1N1 influenza. So based on the respective clinical findings in each of these diseases, including like hepatosplenomegaly in malaria, like hepatorenal involvement in leptospirosis, eschar formation in scrub, severe high-grade fevers with joint pains in chikungunya, or more typical high-grade like fevers with more predominant upper respiratory tract infections in H1N1, or any localizing signs pertaining to febrile illness per se, including burning micturition, renal angle tenderness, jaundice, any skin and soft tissue infections. Everything should be ruled out in spite of patient having the RT-PCR positive. Like if there are any other signs which are not explained by COVID-19, then it is really a good idea to actually look for any other co-infection. So if the RT-PCR is negative or if COVID negative also, then we have to assess clinically for H1N1, dengue, typhoid, leptospirosis, scrub typhus, or chikungunya. And if clinical suspicion persists, repeat COVID-19, RT-PCR or other tests. So this is data which is actually published from the World Health Organization Southeast Asian region handbook on dengue. So this has these are the two graphs which have been showing mostly during the first wave pandemic in India, especially during the early months of the 2020. So these cases, this graph actually shows the vector-borne diseases along with that of with respect to COVID-19 pandemics in India. So we can actually see from this particular graph that there is not much decrease in the incidence of any other vector-borne diseases. It's just that the COVID cases have risen gradually over the months as the pandemic has built up. So this is similarly, this is an age group comparison between patients who are having dengue and COVID-19 during the first wave of the pandemic. We can see that as the age progresses, the 21 to 30 years of age group is actually showing a higher incidence of both dengue and COVID-19, whereas we can see as the age progresses, the incidence of dengue is slowly coming down, whereas the incidence of COVID-19 is coming up. So this we actually have known, this is a known fact during the first wave of COVID-19 pandemic. Now coming to co-infections. So the co-infections of dengue can also occur. So when do we actually suspect a co-infection is what we've discussed previously, when there are any other atypical symptoms pertaining to acute febrile illness other than COVID-19. But the problem with this, there is a high incidence of COVID-19 dengue co-infections, and especially both of them have a chance to be asymptomatic. So if it is symptomatic, then it could be a COVID predominant co-infection, dengue predominant co-infection, or a codominant co-infection. So based on these parameters, the guideline says that in an asymptomatic co-infection, it is reported in 70 to 80% of the cases, and both of them are either asymptomatic or mildly symptomatic. In COVID-19 predominant, the case will have more COVID-19 symptoms like LRTI, like cough, fever, shortness of breath, X-ray infiltrates, CT suggestive of COVID-19, and signs and symptoms of mild to moderate dengue fever, which include high-grade fevers, joint pains, retroorbital pain, etc. If it's a dengue predominant co-infection, which is present with fever, headache, or retroorbital pain, and sometimes might have some respiratory symptoms pertaining to or CT or chest X-ray changes suggestive of a mild to moderate COVID-19. When it comes to a codominant co-infection of COVID-19 and dengue, so there is concurrent manifestations of respiratory symptoms as well as manifestations of dengue fever. So both the infections are severely manifested, and co-infected patients will be having a dominant dengue COVID-19 or a codominant infection, but a codominant infection is relatively more, it is associated with higher morbidity and mortality. Why? Because both of them are known to potentiate each other virulence, and we have a very tough case to deal. So for all the above categories, the confirmed case is only labeled or microbiologically proven. The proven COVID-19 is that which is proven by an RT-PCR, or a proven dengue case is for an NS1 antigen or IgM positive, whereas the other cases will be a probable case. Now, what are the various specific therapeutic challenges in co-infection? So what are the various therapeutic challenges in co-infection includes the fluid therapy. So here we have, suppose in a co-infection, it's during a dengue infection, in order to bring down the hematocrit, we'll be using a lot of IV fluids. So IV fluid therapy is imperative in dengue infection. Whereas if the patient is having a co-infection with COVID-19 and the patient is actively having ARDS, our fluid therapy should be restricted. So we have two antagonistic methods of therapy for a co-infection in a single patient. So ideally, it is advised by the guideline to use a static or a dynamic responsive fluid responsiveness, like an inferior vena cava measurement, so as to guide our fluid therapy to giving optimal fluid therapy to these patients. And low molecular weight heparins. So low molecular weight heparins are imperative in the treatment of COVID-19 patients. However, if the patient is having thrombocytopenia, or giving low molecular weight heparins in these conditions may actually precipitate bleeding for a co-infected patient. So in here, they actually say that for a patient whose platelet count is less than 1 lakh, low molecular weight heparin should be used with absolute caution. Whereas for steroids, so it has been shown that the steroid therapy is actually helpful in COVID-19 patients. But so the dengue fever does not actually pose any challenge, or steroids does not pose any challenge in case of dengue fever. So we can use steroid in a co-infected patients, like how the guideline guides us in COVID-19 patients. So in tocilizumab also, tocilizumab can also be given in co-infected patients as per COVID-19 guidelines. So why is there co-infection? So like how are these two viruses compatible so as to cause a co-infection? So because co-infection is not so common among various other viruses, as we know. So there are other factors which are actually responsible where the two viruses in question are compatible so as to cause a co-infection. So what are the virological parameters? Now, virological parameters include the class of viruses. Both the dengue virus is actually consists of 4 serotypes, namely dengue 1, dengue 2, 3, and 4. So all these four serotypes belong to the family Flaviviridae, and these are more phylogenetically related to each other and share a common antigen pool compared to other flaviviruses. So this, whereas coronavirus, the COVID-19 virus or SARS-CoV-2 as we call it, is actually a coronavirus. It's also an RNA virus, the largest of the RNA viruses. So both of these viruses share both of these viruses have a positive single-stranded. Both are single-stranded RNA viruses. So these both belong to the same class, namely Baltimore 4 class. So Baltimore classification is something which is actually classification of viruses based on their genetic material. So it's a positive sense single-stranded RNA virus belong to Baltimore class 4, and both of these viruses, namely dengue and coronavirus, belong to Baltimore class 4. So these also share a virulent factor. Like they tend to multiply most in the host cytoplasm. So because they tend to multiply in the host cytoplasm, the host factors also in combating these infections are much more similar than we actually assume. So why is that? So it is that dengue viruses consist of certain structural proteins and non-structural proteins. So structural proteins other than the core protein are the membrane protein and the envelope protein. And other non-structural proteins, the NS proteins as we call it, are 7 in number, namely NS1, 2A, 2B, 3, 4A, 4B, and 5. So these are the non-structural proteins and the non-structural proteins. So regarding the structurality of it, then the dengue virus, when it is actually introduced into the skin, it is taken to the nearest lymph node, or the T cells and the B cells are exposed to the antigens by the Langerhans cells. So there, based on this, based on this, they actually mount an immune response. The immune response consists of two types of antibodies, namely the effective antibodies or so-called the non-effective antibodies. They don't actually mount an immune response, but they in fact do more harm than good. So what are these effective antibodies? So the antibodies which are produced against the E antigen of the dengue capsid are supposed to be protective in a patient who's having a dengue fever. Whereas the antigens which are produced against the pre-membrane, that is pre-M antigen, and also the NS1 antigen, so NS1 antibody, these two are not protected. So in the sense, they don't offer or confer any protection towards the dengue, but these antibodies create a problem such that there is something called antibody-dependent enhancement. So this antigen actually binds with the dengue virus, causes an antigen-antibody complex, and this antigen-antibody complex enhances the entry of viruses into the host cytoplasm. So this is what is called an antibody-dependent enhancement. Similarly, when the antigens are actually presented to the T cells and B cells, so the T4, the CD4 cells and the CD8 cells, so they actually release a lot of interferons, like a lot of interferons, interleukins, etc., and they can mount what is known as a cytokine storm syndrome. So as you might have noticed, COVID-19 also is notorious for actually causing something similar to cytokine storm syndrome. So it is actually the pathogenesis when it comes to dengue fever, whereas we know the pathogenesis of COVID-19, where it actually enters the respiratory epithelial cells via the spike protein, and after it enters the respiratory spike protein, it actually invokes a local inflammatory response. The local inflammatory response causes antibody production, and this antibody can also cause antibody-dependent enhancement. Whereas, and also these antibodies, these particular viral antigens are presented to the T cells, where CD4 cells and CD8 cells are presented these antigens, and they may also mount a cytokine storm syndrome. So we can actually see that the pathogenesis is much more eerily similar, in the sense that there is a cytoplasm entry of cell of a viral particle into the cell, the multiplication of viral particle in the cell, where the body mounts an immune response, namely an cell-dependent response and an antibody-mediated response. The antibody-mediated response can cause antibody-mediated enhancement, whereas a cell-dependent response can actually throw up into a cytokine storm. So both the evasion strategies of host to these very similar viruses is also similar, in the sense that there is no surprise that they can cause a co-infection. So, like, what is the pathophysiology of dengue fever? So, in mosquito bite causes the dengue fever, the dengue virus to be injected, so which can affect by two mechanisms, namely the direct cellular injury called the cytopathic effects, the so-called cytopathic effects of dengue fever, which includes the endothelial cell damage, there is macrocyte activation, there is platelet destruction, and the indirect injuries, which occurs because of, as we've just discussed, the antibody-mediated enhancement and the cytokine storm, which may cause vasculopathy, which cause leaky capillaries, coagulopathy, increase in APTT, and also decrease in platelets, cytopathy, which includes end-organ issues, and organopathies. So all of these might cause massive shock, massive bleeding, and multi-organ failure. So how do we classify a dengue infection? So after we confirm the case of dengue infection, we can classify it as a symptomatic infection or an asymptomatic infection. The symptomatic infections can be again divided into mild, moderate, and severe. So the mild infection is just like fever with 2 to 7 days with any of the nausea, vomiting, rash, headache, myalgias, etc. Whereas moderate dengue infection is actually encompasses two variants, namely with high-risk comorbids and with warning signs and symptoms. So any patient with high-risk comorbid conditions, in spite of not having warning signs and symptoms, come under moderate dengue. The high-risk comorbid conditions include infants, old age, pregnancy, immunosuppressive drugs, chronic infections, chronic illnesses like chronic liver disease, coronary artery disease, bronchial asthma, COPD, CKD, etc., or any other pre-existing coagulation disorder. Dengue fever with warning signs and symptoms. Now, what are the warning signs we are talking about? It includes the recurrent vomitings, abdominal pain, tenderness, lethargy, cold clammy extremities, rapid pulse, narrow pulse pressures, hypotension, hepatosplenomegaly, progressively increasing hematocrit, and rapid falling platelet counts. Severe includes shock, severe multi-organ involvement, and there is severe bleeding manifestations. So it's actually ideal to classify this disease as mild, moderate, and severe because it's in the setting of co-infection, as we'll be seeing in the coming slides, that dengue is actually classified as dengue class A, class B, class C in order for us to classify a co-infection. So these mild, moderate, and severe are actually classified as class A, class B, and class C. Now, what are the various gradings of dengue fever? This is the World Health Organization grade. So any fever with any two of the following, namely headache, retroorbital pains, myalgias, bone pains, rash, or hemorrhagic manifestations, with no evidence of plasma leakage, with the laboratory findings including leukopenia, thrombocytopenia, rising hematocrit with no evidence of plasma loss, it's actually defined as dengue fever. So if there is evidence of plasma leakage with thrombocytopenia less than 1 lakh and rise in hematocrit greater than 20%, it is dengue hemorrhagic fever 1. Grade 2 is there is bleeding manifestations. Grade 3 is there is a features of shock, which is compensated. Grade 4 is profound shock with undetectable BP and pulse. So the grade dengue hemorrhagic fever, grade 3 and grade 4 are combined together and they are called dengue shock syndrome. Now, how do we manage a case of compensated shock? So if the pulse pressure is less than 20 with hypotension, with rising hematocrit greater than 20% of the baseline, the initial therapy is to give IV therapy with 10 to 20 milligrams per kg per hour of crystalloid solutions, and we'll observe for 1 hour. So if there is improvement in vital signs and hematocrit, then we'll start to slowly reduce the crystalloids by successfully reducing the flow from 10 ml to like ultimately 3 to 1.5 ml after 2 to 4 hours. And if there is further improvement in vital signs, we can discontinue IV fluids after 24 to 48 hours. However, if there are no improvement in vital signs, we have to check for hematocrit. So if there is a rise in hematocrit, then it is persistent plasma leakage. So IV colloid or crystalloid should be again given. Or if hematocrit falls, in spite of not actually like improvement in vital signs, then we have to suspect bleeding. So it's ideal to give blood transfusions, whole blood or packed RBC. So if there is refractory hypotension, we have to look for airway breathing, calcium, and other electrolytes. If there is no improvement in vital signs, then it's imperative to start them on vasopressor support and crystalloid maintenance dose with holiday cigar formula. So then in case of profound shock, signs of shock with undetectable BP, then there is immediate rapid volume replacement of 10 to 20 ml per kilogram, which is given over 15 to 30 minutes. And if there is improvement in vital signs and hematocrit, then we'll start to slowly reduce the IV fluid therapy, and further improvement in vital signs, like we can discontinue the IV fluids after 24 to 48 hours. When it comes to no improvement in vital signs, we have to repeat another bolus of 10 to 20 milligrams per kg body weight of crystalloid or colloid. Colloids include dextran 40, degraded gelatin polymer, etc. So we have to check for hematocrit. So if there is hematocrit is improving, the pathway changes, whereas hematocrit is rising. Similarly, we have to give colloids or colloids or a crystalloid. If hematocrit further falls, we have to suspect bleeding and blood transfusion is to be given. there is refractory, even if there is refractory hypotension, we have to look for other causes of hypertension, including acidosis. There is ongoing bleeding, like we have to check for electrolytes, including calcium, sugars, etc. So if there is no improvement in vital signs, we have to go for IV vasopressor supports and IV fluid maintenance with holiday care formula. In both of these, it's like the guideline actually supports giving blood transfusions as opposed to platelet transfusions in patients with dengue. They actually say that the platelet transfusion is not actually going to help any more than what we any more than this guideline, but it is going to add more fluid and it might cause fluid overload. So what is the expanded dengue syndrome? So expanded dengue syndrome is actually a rather atypical manifestations of dengue or a concomitant manifestations as a spectrum where they can cause end organ involvement. So the other so almost all the organs in our body can get affected in expanded dengue syndrome. So this particular table is based on some anecdotal reports which are published across various journals. So the neurological manifestations include febrile seizures, encephalopathy, aseptic meningitis, intracranial hemorrhages, subdural effusions, even Guillain-Barré syndrome, transverse myelitis, gastrointestinal or hepatic includes fulminant hepatic failure or hepatitis or hepatopathy, which is like common, and we'll be discussing it quite in detail later. It can cause acalculous cholecystitis, acute pancreatitis, parotitis. The renal include acute renal dysfunction, like acute kidney injury. So acute kidney injury in case of expanded dengue syndrome is most costly because of interstitial nephritis, and it may also cause hemolytic uremic syndrome. Cardiac involvement include conduction abnormalities, myocarditis, pericarditis. It can also cause ARDS. The musculoskeletal involvement includes like myositis and rhabdomyolysis, and especially in certain rare cases, it may cause hemophagocytic lymphohistiocytosis, and that is one of the other causes which can cause high mortality. There could be spontaneous splenic ruptures, lymph node infarctions, macular hemorrhages, impaired visual acuity, and others. So this expanded dengue syndrome is from this particular article from the Tropical Medicine, which is actually quoted by the World Health Organization in the definition of an expanded dengue syndrome. So coming to dengue hepatopathy. So the dengue hepatopathy, it's like most commonly occurs in dengue virus infections, and like liver is the most commonly affected organ in fatal dengue cases. The pathophysiology of liver impairment in dengue virus is not clear. So there are two major postulations such that it could be because of the direct cytopathic effects of the dengue virus onto the liver, on the hepatocytes, or it can also be because of the profound shock or bleeding, which can cause secondary causes like ischemic hepatitis and everything. So these acute liver failure, so that's what the acute liver failure has been reported in association with prolonged shock, but it also has been reported to occur in the absence of shock. Absence of shock can be because of the cytopathic effects. So they are directly or indirectly. The postmortem studies, despite in these patients who are having acute severe hepatitis with dengue, the hepatocellular necrosis is mainly in zones 1 and 2. It's most probably apoptosis or the congestion of hepatic sinusoids or hepatic steatosis in almost all fatal dengue cases. So the clinical spectrum of dengue hepatitis range from mild asymptomatic elevation in transaminase levels to fulminant severe hepatic failure. So there is a meta-analysis which had said that a patient with liver enzyme abnormalities in patients with dengue found that 80% of dengue hemorrhagic fever and 75% of dengue fever had AST abnormalities, whereas 54 and 52% has got alanine transaminase abnormalities. So AST is generally elevated greater than that of ALT, which is a typical dengue injury pattern. So it actually distinguishes dengue hepatitis from other viral hepatitis. The higher levels of AST is also seen due to other release of AST from the non-hepatic cells, especially from the skeletal or the cardiac cells. Now there are like interesting articles which actually try to predict the mortality from dengue fever. So there is an article which is published in 2017, which had a score called the dengue fever mortality score. This dengue fever mortality score has taken into consideration 5 variables, namely age, hypotension, that is systolic blood pressure, age greater than 65 years, hypertension, that is systolic blood pressure less than 90, hemoptysis, chronic diabetes mellitus, and chronic bedridden state. So these are the 5 parameters, and each parameter is given a point of 1. So they have actually postulated that for any patient whose score is greater than 3, they have a higher mortality, and this particular score is said to have a sensitivity and specificity greater than 92%. So then there is another article which actually I try to identify as the severity of the infection marker. This included the aspartate aminotransferase and platelet count ratio. So this aspartate aminotransferase is actually presented as a ratio of the upper limit of normal, and the platelet count is actually taken as the number of lakhs. So if it is 1.5 lakhs, the platelet count should be taken as 1.5. So this ratio is a predictor of a more severe viral infection or a more severe mortality in case of dengue fever. This particular aspartate aminotransferase by platelet ratio was initially used in predicting hepatic fibrosis in chronic hepatitis C patients, but this has been extrapolated or tried in dengue fever in this particular article. Whereas they have actually found out that a patient with non-severe dengue infection has got this ratio of 3, or the mean ratio is around 3.02. Whereas in case of its severe infection or with patients who have died because of dengue fever, this ratio is as high as 13. So according to the ROC curve, they have actually said that a patient whose ratio, aspartate aminotransferase by platelet count ratio, is greater than 6, they have a more risk of mortality from dengue infection. So coming to dengue-associated acute liver failure. So the dengue-associated acute liver failure is an uncommon complication. So the incidence is low. Like it can be ranged from 0.31% to 0.77%. Prognosis is poor, however, with higher mortality rates of 50 to 65%. So like how do we? So we have actually treated patients with acute liver failure in because of dengue infection. So the mortality rate remains to be quite high. So is there any method to actually predict acute liver failure in dengue infections? So here we have. So if according to this article, which is published by this Kumarasen et al., so they have actually said that the elevated transaminase, like aspartate transaminase greater than 1000, and the presence of any 2 out of these 3, including elevated serum bilirubin, elevated alkaline phosphatase, or persistent nausea and vomiting. So they have the higher incidence of going to ALF with 93.8% sensitivity or 98.7% specificity. So there is also another article which was published in American Journal of Tropical Medicine. So they said that the baseline risk factors for the patient to go into, or the patient for the development of acute liver failure, were the age less than 40 years, a greater than 10% of atypical lymphocytes, and a platelet count of less than 50,000 per millimeter. So this has actually identified these subset of populations are at a higher risk of going into acute liver failure. So how do we treat acute liver failure in these patients? So there are certain drugs of choice, but whereas even though it is not actually completely, we don't know for sure whether intravenous or N-acetylcysteine is going to act in these patients, but there has been certain reports where they've actually tried in these patients and it actually helped. So in this particular case series, they have used intravenous N-acetylcysteine in acute severe hepatitis. They have given it in a dose of 100 mg per day transfusion, 100 mg per hour, 100 mg per hour infusion over 3 to 5 days, for 3 to 5 days. So they have actually given around 2.4 grams of N-acetylcysteine per day for 3 to 5 days. So that is their method, and they actually found out that it has actually helped patients in patients with severe hepatitis. And coming to, this is an article which is published in Journal of Critical Care Medicine, India. So N-acetylcysteine in dengue, in fact, associated severe hepatitis. So N-acetylcysteine in this is a case series actually. So they have also given 100 mg per kg per day in these patients. So that is what they have they dosed in this particular scenario is. However, in this particular article of intravenous N-acetylcysteine by Kumarasen et al., so they have actually they have given N-acetylcysteine in paracetamol poisoning doses, namely 150 milligrams per kg over 6 hours, and then coming down accordingly. So in all these case reports, we don't have all these are anecdotal case reports, and we don't have any specific evidence or a randomized control trial which actually showed the efficacy of intravenous or N-acetylcysteine in treating patients with severe hepatitis or acute liver failure. So these are anecdotal case reports, but we are using intravenous N-acetylcysteine in these patients with dengue-associated acute liver failure patients. Or the next step is that there is like evidence that there is high volume plasma exchange is useful in patients with acute liver failure. So this article by Larsen et al., so they have actually taken into consideration all patients with acute liver failure. This particular article is not limited to dengue acute liver failure patients. So they have actually taken all the other causes of acute liver failure also. in fact, viral acute liver failures are quite less in this particular study, but they have postulated and they've proven that high volume plasma exchange is actually helpful in patients with acute liver failure, and it decreases the chances of the patient going to liver transplant. So extrapolating the same, a team from Delhi, they have actually done therapeutic plasma exchange as a rescue therapy in patients with severe dengue with hyperferritinemia and acute hepatic failure. So this article from so this team from New Delhi has this particular study has taken into consideration 3 patients. So this is a case series of 3 patients. They say among the 3 patients, one made it alive, but the other 2 patients sadly passed away. But among the 2 patients who died, there is one patient who actually got better from the acute hepatic failure component, but later died because of other reasons, like he had a cardiac arrest. And even the guidelines by the World Health Organization for dengue and dengue hemorrhagic fever, if nothing else works, they ask to consider plasmapheresis or hemodialysis in cases with clinical deterioration. So even if everything fails, so liver transplantation for acute liver failure is one of the options, but there is not much case reports also in this modality. There is only one case report which was actually reported from Toronto. So they have actually said that the liver transplant, so it was to a 44-year-old female who contracted dengue elsewhere and was shifted there with acute liver failure. And then they have actually done a liver transplant, after which the patient survived. So this is how, as I was actually going through all the literature, this is actually an interesting case which was actually published in American Journal of Tropical Medicine, where they actually have reported a case where of a dengue COVID-19 co-infection, where this is actually the timeline of the infection. So initially the patient was tested NS1 positive during the initial stages, and he subsequently developed thrombocytopenia requiring platelet transfusions, but later he actually developed bronchopneumonia, and the bronchopneumonia was progressive in spite of the platelet count improvement. So then they've actually done a RT-PCR which was actually tested positive for COVID-19. So then they have to and he developed more severe respiratory infections. So that was managed in those lines. So this particular slide is actually showing the probable course, or is an example of how a dengue COVID-19 co-infection can go. So the patient was actually there in the hospital for about 15 days. So this is how it actually went. He went home. So this is, thank you.
Thank you, Charan, for that overview. And with this, I think we will take questions and interactions. I request all the participants to put their questions if they have anything in mind. So the last 2 years, close to 2 years, has been rolled on with the COVID pandemic. But we know our old friends, the dengue, the chikungunya, the scrub, the lepto, the enteric fevers, the common influenza-related flu, and H1N1. These all been common, which will obviously come back. So thankfully, the last 3 or 4 months, the COVID transmission rate was low in our places or in our states. And we have seen a decline in the rate of COVID admissions and COVID inpatients. But there is a stiff increase in other fevers, particularly in the last 2 months. In the month of September and October, we have seen a stiff rise in fevers in both pediatric age group and in young adult age group coming to the hospitals, walking to the hospitals, and few of them requiring admissions. And dengue is one of the predominant one. So in this context, I just wanted to know the experience and opinion of our senior clinician, Dr. M.V. Rao sir. In this current era of 2 years of pandemic, the whole world has been focused for a particular disease pandemic, that is COVID, and every fever, every SARI, acute respiratory illness has been leveled as, every fever has been leveled as COVID proven otherwise. In this context, now the routine regular tropical fevers, routine regular infections, which has been a part of our life for the last few decades, they came back. So in this situation, how are you handling, sir? how do you actually evaluate and differentiate these kind of fevers from the existing COVID pandemic?
Good evening, all, and good evening, Dr. Venkatraman and Sricharan. Sricharan, that was a wonderful presentation, right from the epidemiology to the pathogenesis to the treatment, also review of literature. So as Dr. Venkatraman says that during the initial part for the first year of the pandemic, as you all know that we have not seen any other case, no dengue, no chikungunya, no malaria, very, very few cases, no hepatitis, no enteric fevers. For reasons unknown, probably people are at home taking care of their health, probably following all the hygienic precautions, and maybe keeping their homes clean. And not only that, dengue fever usually comes in epidemics in every alternate year. So 1 year prior to the pandemic, there was a dengue epidemic. We have seen a lot of cases. So during the initial 1 year of the pandemic, probably the dengue was actually lying dormant. Now this year, we are seeing dengue patients, but not as we have seen 2 years ago. So now the problem comes with all of us, like physicians, general practitioners, and critical physicians. When a patient comes with acute febrile illness during monsoon, what you do? So if the symptoms are classical, like you have sore throat, you have cough, running nose, and you have loss of taste sensation, you have probably straight away you can say that it is COVID. And as Sricharan says that because the viruses share some antigenic properties, because of cross-reactivity, and sometimes we may miss co-infections. And as the treatment is entirely different, dengue treatment, COVID, sometimes we may land up in problems. So as he says that dengue causes coagulopathy, and whereas COVID causes thrombogenicity. So the exactly opposite. So we got to be very careful. In fact, I have seen 2 cases during the season where dengue and COVID were coexisting. So probably we're missing many of dengue or COVID in these patients also, we exactly don't know. And any patient comes particularly to a referral center to us, we cannot miss a diagnosis. So a patient comes with acute febrile illness, if the symptoms are atypical, please get CBP. Suppose simple CBP shows that leukopenia or lymphopenia with almost normal platelet count, think of COVID. Suppose if there is a leukopenia and probably thrombocytopenia in the first 3 or 4 days, probably should think of the dengue. And if there's leukocytosis and thrombocytopenia, think of other friends like staph typhus or leptospirosis. Of course, these are only a wide, rather rapid, rather rough guidelines. I cannot say that it is hard and fast rule, but it's only suspicion. But to be very sure, particularly when we get a lot of referrals from district hospitals, get a CBC done, and don't forget to get COVID tests in every patient. Rapid antigen test followed by the RT-PCR. And also get the parasite F and V done, because the rapid test, they usually don't go wrong. And of course, if you have suspicion, go for staph typhus and other tests so that you should not miss any diagnosis. And if there is, unfortunately, if there is a positive report of both dengue and COVID, I think very, very careful. And we have to treat depending upon the predominance, which is predominant, COVID or dengue or both. Then, of course, Sricharan has elaborately explained how to handle these cases. But in my experience, now we are getting a lot of staph typhus cases. We are giving atypical dengue cases. In fact, right now we have a patient in acute phase. In the first 3 or 4 days, patient went into cytokine storm. So that patient being seen one of my other colleagues. So now we are stuck up what to do. So these patients come to us because we are tertiary care center. So we got very careful, probably look for the newer treatments in dengue, because unfortunately, dengue is a third world country disease, so there is not much improvement in the armamentarium. If you look at COVID, within a year, we got vaccine, you have got so many therapeutic modalities. But unfortunately, dengue, though it was there for a few decades, more than half a century, we don't have many drugs. So now, as Dr. Sricharan explained that we have cytokine storm, why don't we use some drugs to suppress cytokine storm, like baricitinib and other immunomodulators or JAK1 or 2 inhibitors? So in fact, one patient we started now, so because there was few papers on these treatments. Go to Venkatraman.
Yeah, sir, you rightly as pointed out, these both the conditions, COVID and dengue, majority of them can still be asymptomatic. They may not have any symptom to manifest, and maybe even unnoticed to the patient and the clinicians in them. So as you pointed out, we have seen a surge in not only just a dengue cases, we have seen a surge in the seasonal influenza and including H1N1 and respiratory typical SARI symptoms like bilateral infiltrates with atypical pneumonia, not just viral, but also a bacterial. And as you pointed out, scrub has been again a phenomenon here. Few of our cases where you have a leukocytosis, procal positive, lymphadenitis, hepatosplenomegaly, and then scrub came positive in few of them. And leptospirosis also has been noted here and there with cases coming in all our hospitals. So what it exactly says, as you said, sir, the routine, regular, the tropical fevers, viral fevers, seasonal flu, and dengue is back, and they probably is because of, as you said, the withdrawal of lockdown. The public is now, the population is now slowly getting back to the normal life, and the season of rainy season, water, and everywhere, maybe this is all adding to this mosquito breeding and causing the same kind of thing. And even the mask strictness which was there in the first wave, slowly somewhere we are seeing is missing. But so the second part of question is, now we have realized that we have multiple other common tropical and seasonal diseases are on board. But sometimes when these patients are admitted, for example, a dengue case gets admitted to you and a COVID case gets admitted to you with a typical dengue or a COVID phenomenon, but later on you find it to be having a co-infection. So in this situation, when do you suspect? Suppose a patient with a COVID admitted, you suspect for a dengue, or a dengue patient admitted, you suspect for a COVID. When do you suspect them to have a co-infection?
The problem with the diagnosis of COVID doesn't arise because almost all of us check for the COVID, both rapid antigen and RT-PCR before admitting. In fact, initially when we were not getting the RT-PCR easy level, we were even going to the extent of doing a CT scan screening. So somehow we are not missing COVID, but dengue is being missed in COVID patients. So that you should be very careful. So when the patient comes with symptoms of COVID, like breathlessness, lung infiltrates, and hypoxia, if they have COVID, predominant COVID plus predominant dengue, then the problems start, because fifth or sixth day, platelet starts coming down, APT goes on increasing, and by the time we already started, low might happen in these patients because of hypoxia. So my take is that in such patients, you should stop low mercury heparin immediately. The platelet is more than 1 lakh, then go for unfractionated heparin because the action is only 6 to 8 hours. So in case of bleeding, you can tackle, of course, you can give antidote in both of the drugs, but heparin is, unfractionated heparin is short acting. So better to switch over to unfractionated heparin. The moment the platelet starts coming down to 1 lakh, stop that. And in these patients, please check the platelet count twice a day. And packed cell volume at least 4 to 4. I do check 6 hourly. And if you have facility, and you can go for IVC check. So such patients, you have to monitor very closely, because the sheet anchor in the treatment of dengue is fluid replacement. If that goes beyond a point, then these patients go into respiratory failure, where fluid restrictions come very essentially in the COVID patients. But if you delay, if you really neglect fluid, patients may go into shock, and that results in multi-organ failure and they die. So it's very, you should treat the patients very, very carefully, and monitoring is very important. You must train your juniors, you must train the nurses. They should pick up the warning signs, and they should pick up the increase in the hematocrit and alert immediately and give fluids then and there. So that's how we monitor. One patient, a young girl of 30 years came. She had both predominant COVID and also dengue, but so fortunately she went home safely.
Yes, as rightly pointed out, sir, in situations with COVID, we have seen all kind of permutation combinations and organ system involvement, from the rash to the joint pains, to the body pains, to the headache, to many things. Every system has been involved, and the very atypical presentation from respiratory to GI to all the kind of spectrum of permutation combination has been seen in this COVID. So suspicion in COVID with any form of atypical presentation should be there. And as you rightly pointed out, the COVID should come on to board if somebody in the early part of this illness started rapidly dropping platelets and having a polyserositis, which is not very commonly seen. We see a bilateral effusion, if you are a collection ascites there, and you see a thin brim of pericardial effusion, and the polycythemia is a typical picture with a raised hematocrit.
GV wall
All
thickening
this-
is, yeah.
Yeah, so these all add to a typical like retroorbital pain and headache, body pains, which are disproportionate to these needs a suspicion, as you pointed out, and that adds to them. And as Sri Charan has pointed out, Government of India given a guideline that one disease can be predominant, the other can be very mild or asymptomatic, like a predominant COVID-19 with a very mild or asymptomatic dengue, a severe dengue with a asymptomatic or a mild COVID. But the challenge comes when both are predominantly involved, as you've seen in your patient. So when this comes into play, when I have a severe dengue and a severe COVID pneumonia or ARDS in place, then the treatment takes a task. For example, in this situation, in dengue, I need a overzealous or a maybe a good amount of volume resuscitation to see that this intravascular volume has been replaced, the capillary refill, the capillary leak which caused the intravascular volume depletion is replenished. But whereas in COVID pneumonias or COVID ARDS, we make sure that they don't go into overload and maybe optimal balance has been attained. In the same way, as you said, ki anticoagulation in COVID, which is probably most of us use in both therapeutic and prophylactic doses depending on the need. Whereas in dengue, we all know that you may go into a coagulopathy early, and you may have a thrombocytopenia coming. And we also have a problem as a steroids. In most of the dengue patient, we don't use steroids, whereas in a COVID who needs oxygen, we use steroid. So how do you take all these three, including Amy, some of the times you said tocilizumab use, and you also pointed out baricitinib. So in situation where both are overlapping, how do you handle them?
Yeah, if the both are overlapping, both are probably having predominant symptoms, then which comes first? Suppose in COVID, when you see the onset of disease, if both are the same time, both of them have severe symptoms the same time, that becomes really difficult. Such patients to be admitted under critical care and should be monitoring every hour. So the most important thing in COVID is hypoxia. So manage hypoxia with whatever, depending upon the requirement, like nasal prongs to the non-invasive ventilation to the ventilator. Second thing is coming to the fluid. So you have to check. One is hematocrit every 6 hours. In fact, some literature check it every 2 hours. Keep the centrifuge in the critical care unit and go on doing it every 2 hours. Maybe difficult sometimes, but at least you check it every 6 hourly, and that guides you the amount of fluid to be given. Number 2 is IVC. So because all 3 centers in a hospital have that facility, so we check IVC and give fluids accordingly. So that is about the fluid. Second thing is most importantly about the heparin, anticoagulation. So I suggest to you, if the patient comes predominant symptoms of both COVID and also dengue, go for the unfractionated heparin, where in case of bleeding, in case of low platelet count less than 1 lakh, you can stop that immediately. So within 6 hours, the effect of this heparin goes off. Third is coming to steroids. So unless there is a GA bleed, you can use steroids safely in patients with COVID plus dengue, because steroid has a major role in the therapy. The therapy benefit of steroid is unquestioned. So we have to use steroid unless there is a great contraindication, a strong contraindication like GA bleed, because GA bleed is seen very common in severe dengue. So ensure that there is no GA bleed, then continue steroids. But in the presence of GA bleed, I think the steroids probably have to withhold. So this is about the fluid, about the oxygenation, about the heparin, and about, of course, about steroids.
Yeah, so there are some questions. How to deal with the following situation? A patient with warning signs, 4-5 days of illness, had a pleural effusion, ascites, and is lab suggestive of high hematocrit, raised lactate. Should we give fluids, diuretics?
Yes. Yeah.
What is Mohali?
This is a very common problem encountered with many physicians. So a lot of clinicians really mess with these patients, because when there is a fluid outside the compartment, it's an extravascular compartment. So the bilateral effusion is there. The ascites, patient may have breathlessness because of the pressure symptoms. But if you look at the intravascular compartment, patient has dehydration. If you say hypovolemia, so you have to give IV fluid. There's no doubt about that. The only thing in such patients, you've got to be very, very careful, because when they are recovering, there will be rapid reabsorption of fluid from the abdominal cavity and also from the pleural cavities. And these people go into fluid overload and they present breathlessness. Such patients, we have to probably start diuretics. So whenever there is hematocrit, increased hematocrit, more than 20%, despite having massive pleural effusions, despite having ascites, you have to give IV fluid. But as I told you, be careful when the patient is recovering. Treat them with diuretic if required.
Yeah, absolutely.
On the hematocrit.
Yeah. So these are the situations where they have severe volume depleted state with high hematocrit, and there is a third spacing. The fluid is available, but not into the intravascular compartment. And when you see these patients having a low perfused state, cold, clammy extremities, rising lactate, hypoperfusion, and probably these are the patients who may need volume, or these patients will need volume to rebound back those perfused state. But if they have a massive effusion causing the problem, probably few of the time, if they are hypoxic because of the effusion, they may need rarely a drainage. But as sir said, once your febrile phase followed by critical phase where you see this capillary leak phenomenon, polyserositis, and intravascular volume depletion requiring a fluid, hematocrit guided, dynamic parameters guided like IVC, ultrasound guided, where you see the volume challenges depending on the fluid responsiveness. Once you cross this critical phase, once your capillary leak stops, you see a boogie patient with a third spacing. Once your hemodynamics get better, your perfusion gets better, you probably de-resuscitate them. And some of the times it happens by natural way of diuresis, or some of the time you may need a diuretics, but not in the early part of critical phase where your hematocrit is rising, you have a hyperperfused state, you have a rising lactate. Probably we have a situation, sir, which is a little tricky more than this, where we see some of these patients may land up in myocarditis.
Exactly.
And severe LV dysfunction, or causing that severe pulmonary edema. They were more complex and tricky situations. So any guidance for those patients? They are more complex.
Exactly. The myocarditis is very common. Like the most common organ involved in dengue is liver. Every patient probably has slightly increased either SVO or SVPT. And next organ is the heart. They have some amount of myocarditis, either tachycardia or in the later phase they have bradycardia. But some of these patients going to severe failure. Such patients, the treatment is like any other cardiac failure. And if you look at the literature, the treatment of myocarditis with failure is no different from the treating the failure of the other causes. So we have to probably, if the patient's hematocrit allows, we have to go for diuretic, and we have to go for we have to go for inotropic agents. If the patient's heart rate is allowing, you can go for dobutamine infusion. So take the help of the cardiologist and treat like any other failure. So there's no specific treatment for the myocarditis in dengue. It's like another disease.
So some of these patients may not tolerate a large volume as they have a myocardial dysfunction or cardiomyopathy, and maybe they need a vasopressor support for sometimes till the myocardium gets better. And some of these patients may need a deloading of volume in individualized situations, and may need a support by non-invasive ventilation with a PEEP or a invasive ventilation if they are low perfused. So to counterbalance this pulmonary edema and supporting the myocardium. So this is a balance act there. There were some questions, sir. The initial choice of fluid, which we all understand to treat, is crystalloids, and probably the balanced crystalloids, or a saline up to maybe 2 to 3 liters. But there were questions related to colloids. So can we have any option of using colloids?
Yes, definitely. Actually, the crystalloids are preferred. If the patient fails to respond, you can initially give 3 to 5 ml per kg, but then go 10 ml, then go 20 ml, there's no response, then you can go for the colloids. So any colloids at Dextran, you can give sometimes, no, it's not mentioned in the recent guidelines, but they can give 5 to 20% of even albumin also. But sometimes the patient cannot afford initial days of about 15 years, we were giving plasma. So plasma is easily available, cheap, so we used to give plasma. But now colloids, we have a lot of Dextrans, we can give that. But rarely we encounter this problem. In fact, 99.9% patients do respond to crystalloids. Rarely, probably in children, probably the pediatric chemists say they use lots of colloids than crystalloids because probably they change the body surface and other things. But in adult patients, in my experience, we rarely require fluid other than crystalloid.
Yes. In the last 2 months, in the month of September to October, even though there must be many asymptomatic cases, mild cases, which must not have been reported to the hospital or healthcare system, but there were sick patients who has been coming as a referral unit to us, across the state and maybe the zones which are closer to proximity with the Hyderabad city. We have seen some of them being very sick, even though we have seen patients who are having only thrombocytopenia or warning signs, but few of them being very sick in SOX syndromes, few of them in organ failures, and many of them also been having acute liver failure as a presentation. What was your experience in the last 2 months or so?
Yes, as you pointed out, in fact, probably with the referral center, we are getting more and more cases of dengue with multi-organ failure, particularly acute liver injury, and some patients coming with secondary sepsis, so myocarditis follows. So liver injury, we have seen patients having transaminitis, the ALT, AST going beyond 10, 20, 30,000 also. So initially we thought that could be because of ischemic, because patients going to shock, which is unrecognized, and they're going to so-called ischemic hepatitis. And surprisingly, last few years, a lot of patients did recover from this so-called severe transaminitis, and once we tested them, they used to recover. But we also have lost some patients who are having very bad hepatic failure, so like fulminant hepatic failure and coagulopathy and dying. So it's seen. But of late, as you said, we are seeing patients. We are not seeing the classic dengue fever. We are seeing all patients with atypical features like myocarditis, hepatitis, second infection. Somehow, acute kidney injury is very uncommon. I mean, we are not seeing that frequently, though we have seen previously. This year, we have not seen many patients with AKI. So we've been seeing patients mostly with either myocarditis or hepatitis. So hepatitis usually, that as Srichandran pointed out, I think NSLC definitely has a role. We've been giving in almost all these patients. Whenever the patient has ALT, AST more than 1,000, they do. Then there are some papers which are supporting this. So we do give NAC in all these patients. So, but most of the patients do recover, but some patients really don't do. So maybe the newer variants, maybe the same variant with some change in the genetic this thing, like particularly D2, the intent type 2 probably has some genetic change, and that is according to news all over India. So this is causing more problems. Dengue subtype 2. So maybe that's causing more of hepatitis.
What is your take, Sricharan, on this strain pattern, which Dr. M.B. Rao sir is actually pointing out? Do you think the current virus has more virulency, as causing more organ failure? Is it linked to any variants?
So the variants or the incidence of hepatitis is actually, as sir was pointing out, is more common with dengue type 2 virus, especially the serotype 2 virus. So they actually postulated that this particular virus has got a more cytopathic effects, and it has got both ischemic, like the consecutive effects of ischemia and shock, and also there is a direct cytopathic effect of dengue virus on the hepatocyte. So they say that this dengue 2, this type 2 serotype of this virus is actually more virulent in hepatocytes which are in multiplicative phase, especially the G2 phase. So that is the reason the younger population, especially the pediatric population and the early adolescent population, are more prone to develop this dengue-associated hepatitis and hepatic failure when they are infected with type 2 phase.
Are we seeing, there are questions that are we seeing more cases of secondary dengue in this season than primary dengue? That's why we are seeing a little sicker group. As we understand, a second hit of a dengue with an alternative serotype may cause a severe form of disease.
Could be, because in fact, it's a very good question, Mona Lisa. In fact, whenever a patient comes, most of us do either NS1 or IgM and either IgM and NS1 or both. But every patient, when a patient of dengue, I do IgG also. So IgG positive, that's a warning. You've got to be very careful. Because of previous infection, there may be more complications for reasons what Dr. Srichandran already explained in his talk. So where the patient had already experienced dengue in the past, symptomatic, where IgG is positive, such patients going to severe dengue or expanding dengue syndrome. So got to be very careful. You should keep a close eye on them. So close watch on them. So that's very important. So check IgG in every patient who's admitted. So NS1 is positive, IgG is positive. Then you got to be very careful, because first, or at least in 7-8 day, is going to have problems. So probably this season, because 2 years ago we had a dengue epidemic, so now we are getting dengue from all these patients of secondary dengue, which is causing so-called complications.
In 2019, as you pointed out, we had a highest number of dengue cases reported in Hyderabad. If I look at the list of the India from the Ministry of Health, that I think that we had the highest number of cases, and we have seen a lot of surge in dengue in all the hospital beds, and many hospitals were almost running full at that time. Just pre-COVID, we had all the hospitals beds were occupied badly. Sri Charan, if initially we thought many of our cases when they came with dengue with a transaminase of few thousands, we initially thought, is there any phenomenon of shock lever then dengue causing hepatitis? But later on we saw many patients whose hemodynamically were reasonably okay with normal lactates initially with a good perfusion state, but the enzymes were somewhere in thousands, and we saw INR going worse much before this hemodynamic instability. Do you see this virus directly causing cytopathic effect and hepatitis in this situation?
Yes, sir. So it has been described that these patients who, in spite of not having or not having any prerequisite to actually develop ischemic hepatitis or liver failure, so these patients who are actually developing, who sometimes may present with significant amount of hepatic injury, like as sir was pointing out, with transaminitis going above 10,000 and 20,000. So they may be actually caused because of the direct cytopathic effects of these dengue viruses, where they have the certain receptors which actually change between the viruses. The natural homing receptors of each virus might be different in each of the case, but they'll be finding their way and they cause direct cellular damage, which might be causing hepatic injury in these patients, other than the other effects like shock liver or ischemic hepatitis we were talking about.
Any other modalities you think has already been discussed about a NAC? N-acetylcysteine has been a modality, and the dose being varied between a dose of such a high to 150 milligram per kg in the initial 6 hours or 100 milligram per hour over infusion for 72 hours. Any other modalities do you think when patient not responding, worsening in this? You mentioned about one or two others.
So actually the other thing could be like this is in the sense that there might be, because N-acetylcysteine, like the mechanism of action of N-acetylcysteine is that it actually repletes the it prevents the oxidative damage of the hepatocytes. So especially being described in paracetamol poisoning. So like there might be oxidative damage of these hepatocytes in these conditions. But what could be the possible mechanism of injury in these patients?
Other modalities of treatment in hepatic failure, Dr.
Like probably liver transplant, all those people talking about that.
Yes, sir. Liver transplant.
Any role of plasma exchange, sir?
Yeah, exactly. Actually, there are a few papers on plasma exchange, not only on the hepatitis, even patients who are not responding, like patient who are suspecting the severe cytokine storm. So plasma exchange has been described. In fact, a few papers support this. In fact, we have a girl now, as I told you earlier, I think we are planning tonight to do plasma exchange on her because she's just not responding to anything. So that's one thing, plasma exchange, and we should now hopefully newer drugs may come into picture like baricitinib or other immunomodulators, as I told you earlier. So let's wait for some more probably work on that. That's one. Second thing is, as Sri Charan was saying, the direct injury to not only liver. In fact, we had one patient a few years ago, a teacher from Pettapalli. We had encephalitis like picture seizure. Yes. So we did lumbar puncture, and out of curiosity, we sent for the PCR to NIV Pune. So that patient came positive for DEN subtype 2, positive on the CSF. So virus was there in CSF. So that shows that these viruses may have direct cytotoxic effect on different organs. Let it be liver, endothelium, or brain. So there is apart from cytokine storm, which damages which is immune mediated. Not only that, probably the dengue virus has a direct cytotoxic effect in many organs.
Yeah, so encephalitis has been a phenomenon which we have seen in few patients as supportive care and a good kind of care. As we understand, either dengue or COVID don't have any antiviral treatment for them. So most of these patients respond to a good quality supportive care. And plasma exchange and a kind of liver transplant will be a rescue therapy in extreme conditions where these patients do not respond, and you have a facility to explore those things. So there were some interesting queries. Probably will, in the limitation of time, these will be the last questions we will take. That if we look this as a cytokine storm,
cytosorb is one thing we have.
So cytosorb or any form of other modalities which we are right now using in COVID should be explored. As I already pointed out about baricitinib. So other modalities, do you think will be a phenomenon here?
I think we should go on working on that. I think because since we are getting a lot of patients now, probably we should probably take the ethical committee's permission and go for the baricitinib, plasma exchange, and other models of
And an immunomodulator role.
Yes,
role in
better
that.
we do the including plasma exchange. So I think we should do.
There is a question of cross reactivities, Richard, and cross reactivity and false positive scrub reports from Dr. Mohan Maharaj. What is your take on that?
So
Yeah,
there is
well,
sir, there is actually a higher incidence of false positivity when we actually tested for both of them, sir. But the actual thing is, if this is taken in the line of clinical context, as we were been discussing, so a patient who is actually COVID positive, because like sir was telling, all acute febrile illness will be tested for COVID, right? So if the patient is having any other atypical symptoms, so these atypical symptoms which are more in favor of that particular drug, so then it is actually imperative then to test for those respective tropical fevers, such that we can have an idea of there is a co-infection. So because there is an incidence of false positivity, we cannot be sure if we actually test all the patients, in the sense that if there is no asymptomatic dengue infection, we cannot pick up in a patient with an asymptomatic co-infection of dengue with a symptomatic COVID-19, because he is asymptomatic, we probably will not be testing him for dengue at all. So
the severity of dengue, what we have seen is in the infant, children's, and more so in the younger adult groups between 20 to 30. But Dr. Misra also wants to know, is there any gender predisposition for the severity of this disease? In any
severe amongst men. If you look at slightly more amongst men, the severity more amongst men. As you know, unlike any other disease, dengue is severe in well-built, well-nourished people.
Yes.
Because it's
younger, more immune.
Yeah, it's the antibody enhancement problem.
yes.
Anyone who has a good immunity will have this problem. So the virus goes along with the antigen antibody complex, and probably it cannot be utilized by anything. So it just bursts and releases a lot of variants. So that's how it causes direct cell injury. So it's seen in well-built, well-nourished people more commonly, and for same reasons, probably it's more common amongst men than women.
With this, I think with the limitation of time, I thank Ambira sir for being here, participating, and making this as a learning experience to all of us and sharing his experience. I thank you.
Thank you very much for giving me the opportunity. I really enjoyed it. Thank you, Raman, and thank you, Charan.
Yeah. Thank you, Sri Charan, for reviewing the literature and bringing us the basics and the literature updates. Thanking all the participants who are around and participating in this webinar and interacting with us. Thank you all. With this, I conclude the session. Thank you.
Thank you.